Thanks for joining us. I'm Karen Blum. I am the Health Beat Leader for Health IT for AHCJ. This webinar is one of a series of topic-specific training opportunities to brief health journalists on the latest information in a particular health area and to give you story ideas or resources that you can use in your work. If you have to leave early today, a copy of the recording will be available this afternoon on healthjournalism.org.
Hi everyone, I'm Jyoti Madhusoodanan and I'm the Civic Science Fellow covering race in clinical algorithms at AHCJ. Today's topic is biased devices, reporting on racial bias in health algorithms and products. Doctors measure health in many ways, from routine blood tests for cholesterol or kidney function to devices like spirometers to test lung function or pulse oximeters for blood oxygen levels. But the results of these routine tests can sometimes be misleading because some tests and devices are skewed by algorithms that include a race variable and produce different results depending on a person's race or ethnicity. And some devices don't work as well for people with darker skin tones. These biases can lead to delayed diagnosis and care for Black, Hispanic, Asian, and other communities of color. Clinicians, regulators, and researchers are now working to address health disparities caused by this misuse of race. Today's webinar will cover this complex space of racial disparities in algorithms and devices.
We have two experts joining us today. Michael Shoding is a pulmonologist and an associate professor of medicine at the University of Michigan, and Shazia Siddiq, a gastroenterologist and a health policy researcher at the University of Pennsylvania. Jyoti and I will ask our questions or ask some questions to our experts to kick us off, and then we will be happy to take any of your questions. Please put those in the Q&A space and not the chat, so we will be sure to see them. And Dr. Shoding, we're going to start with you with some questions about pulse oximeters. So can you tell us, for people who are not as familiar with these devices, why are they important in clinical care?
Yeah, sure. So, I think many people kind of have a sense of what a pulse oximeter is, since we heard a lot about them during COVID a few years ago. But basically, it's a little device that you put on your finger, and what it allows you to do is measure oxygen level in the blood. And oxygen level in the blood is a really critical piece of information. It's like a vital sign, and it's used, in clinic, in the hospital, even at home, to basically measure or evaluate a patient's lung, health status. And low oxygen levels can be very dangerous. And so having the ability to accurately measure oxygen is super important for knowing if a patient needs additional care.
Okay. And can you give us kind of a broad overview? How do they work and why do they not work as well in some people who have darker skin tones?
Yeah, so in some respects, pulse oximeter is kind of this amazing technology. What it's doing is this finger clip, it's actually sending light through your finger. And based on how much light is sent through or how much light is absorbed, and in fact, it's sending light through actually at two specific wavelengths. And those wavelengths are chosen because when you have a lot of oxygen in your blood, there's different absorption when you don't. And so it's pretty smart in that based on how much light is going through, the pulse oximeter can kind of measure what is the oxygen level in the blood. And so the problem, though, is that we think that when you have melanin in your skin, it can interfere with that or change the way that light is sent through the skin. So it changes the way the light is sent through the skin, and what ultimately happens is the pulse oximeter can give a false reading. And what it looks like sometimes is that the oxygen level is higher than it truly is in the blood. And so what we've found in a number of studies now is that pulse oximeters tend to miss patients with low oxygen who are self-described as Black, and it's thought that it's due to melanin levels causing differences in how the light is absorbed.
And is there a way that you and other clinicians can correct for that?
Yeah, so there isn't really a great way to correct for it. I think since our study and other studies have come out, there's been really a much greater awareness about the fact that this fingertip device, while in some respects amazing that it can measure oxygen levels in the body, is not sort of perfectly accurate, particularly in certain situations like in patients with darker skin pigment levels in their body. And so I think the main thing that has happened is that clinicians have been a bit more cautious about interpreting the pulse oximeter and just been a little bit more careful. And there is another test out there. It's much more invasive. It's called a arterial blood gas analysis. It requires a special blood draw into the wrist. It's a pretty painful procedure. So, nowadays, if there's a real concern and you really want to know the right answer about what the oxygen level is, that is the sort of gold standard test that's used. And unfortunately, because we are sort of appreciating now that there's inaccuracies in these devices, one recommendation is to use that other more painful invasive test to sort of sort things out, because really, like, right now we're sort of left with the devices that are currently in hospitals and in clinic, and we know based on a lot of real world data that sometimes they're inaccurate, particularly in patients who self-report as Black, and it's thought that that's because of their skin pigment.
Yeah. Are there other replacement technologies that people are researching, or that we might see come to market sometime soon that our audience should know about?
Yeah, I'm hopeful that people are going to see improvements in the device, because, like, fundamentally that's what's needed. I think I described several sort of stopgap measures that physicians are sort of using right now to sort of manage the fact that these devices are less accurate, but these are sort of stopgaps, and they're really not a solution that anyone is particularly happy with or think is particularly just. So I guess what I would say is that people are working on this. There, to my knowledge, nothing sort of as well established on the market that has convincingly shown that the biases that don't have this bias. Some techniques include, like I mentioned, the pulse oximeter device typically shines 2 wavelengths through the finger. So one approach could be using a bunch of different wavelengths all at once, and sort of having more wavelengths equals more information, gives a better estimate. And so I think that's one approach. Others are sort of working on different ways of shining the light through. So there are some people working in this space, but I don't know if any of that technology has sort of made it to the market.
Okay. And then maybe you can also give us an update on this. So I know the FDA earlier this year had a public meeting to discuss some approaches to improve the performance evaluation for pulse oximeter devices, and was also working on some new guidelines. Do you know what's happened since then, or when we can expect these guidelines to be released?
Yeah, and I think this is sort of an important this is an important piece of the story. And so, when we first published our work back at the end of 2020, there was a lot of skepticism about it, frankly, that, like, how could this happen? How could these devices that are on the market actually have these biases? But when you sort of dig down and look closely at how FDA has been regulating these devices, it's sort of surprising at how sort of minimalist the studies have been that FDA is required to get the pulse oximeters to market. So in the current sort of version of guidance, FDA has said, you need to conduct a study that has 10 subjects, 2 of which have darkly pigmented skin. And so that's sort of like has been the standard. And so I think like over the last couple years now, FDA has been meeting to talk about ways to increase, ways to make that testing a bit more rigorous. And so they've sort of suggested maybe going from 10 to 24 subjects, and then also to making sure that there's a broader group of skin tones represented in the pre-market study. And so they had said that they were going to try to issue real actual guidance on this back in October of this year, October 1st. So they have missed that deadline, and they haven't really said exactly why or when they will issue final guidance. I will say that they've had several meetings on this subject. They've really sort of taken this problem to heart and really have seemed to sort of, gone through the process of what it will take to update the guidelines. I think many people feel that they're moving too slowly, just given that like our studies came out at the end of 2020 and so many other studies have come out since then. But I think they're moving at the speed that they're comfortable with, given that what they end up deciding will have an influence on the market and how these pulse oximeters are tested in the future.
Good, thank you.
Thank you, Dr. Shoding, and thank you, Karen, for that overview of the oximeters. I'll turn to you now, Dr. Siddique. If you could start us off with an overview of your recent analysis of the algorithms that include race.
Yeah, sure. I'm happy to do that. Let me just start sharing my screen. So I think what's important is to start off with the definition, which is what is a healthcare algorithm, which is really distinct from a device. So this is a mathematical formula or model that combines different input variables or factors that then informs a calculation or an estimate. So this can be what is your risk of getting a disease, or what is your prognosis once you have a disease. And certain thresholds can be used for clinical decision-making, such as in the example of estimated glomerular filtration rate, also known as eGFR, which is an algorithm that is used to calculate kidney function and diagnose different levels of severity of kidney disease. And thresholds can then be used to determine eligibility for dialysis or kidney transplant. So similarly in 2020, and I think to Dr. Shoding's point, there was a lot of awareness of the problems of race-based algorithms and disparities, but I think many things happened during the COVID-19 pandemic. There was a lot of social movements as well, and greater awareness of health disparities that, now finally these issues came more to the forefront. So this was more of a commentary piece that was published in the New England Journal of Medicine, highlighting that we're correcting for people's race in terms of their disease risks and disease estimates. And some of the problems with certain algorithms were brought up. And after this paper came out, a letter was actually sent from Congress to the Agency for Healthcare Research and Quality. And this letter was written by, I think it was Cory Booker, Barbara Lee, Elizabeth Warren, and they essentially highlight many of the different disparities that existed during the pandemic and different algorithms. You can see here at the bottom, small, but they talk about eGFR there. And so they highlight this issue of race-based clinical algorithms. And in response, the Agency for Healthcare Research and Quality put out an RFP, which also means a request for proposals, to say that, people are publishing certain individual devices or algorithms, but we really need what's called a systematic review, which allows for a much more comprehensive look to better understand the current effect of healthcare algorithms and mitigation strategies on racial and ethnic outcomes. So this systematic review was ultimately commissioned to our team at Penn Medicine and ECRI, which is a collaborating research institute in Philadelphia. And so it took us a long time, probably I think about 3 years. And ultimately the report was published on the AHRQ website, and then it came out in publication format for the Annals of Internal Medicine in March of this year. So what did we do? Essentially, we asked two big questions. The first is, what is the effect of healthcare algorithms on racial and ethnic disparities? And the second is, what is the effect of interventions to mitigate racial and ethnic bias as you're trying to develop algorithms? And the one thing I do want to mention, Jyoti, because I think your question was about algorithms that include race, is we actually, although the congressional letter stated that they were interested in these race-based algorithms, we made an intentional decision to look at all algorithms, regardless of whether they included race and ethnicity. And there were a lot of studies that came up, and I'm not going to spend time, going into details, but I'm happy to answer questions later. But just as a broad overview, this was one of the figures that we showed in the report. And so you can see, this is called an evidence map. And just to orient everyone, on the left-hand column, we're looking at, this is sorted by the effect of the algorithm on racial and ethnic disparities. So there's reduce, no effect, and then perpetuating or exacerbating disparities here. And then each row is an algorithm. And so you can see in this, fourth column here what the algorithm is. And if you look at this middle column, includes race or ethnicity, it's interesting because you can see that some of them include race and ethnicity, but some of them don't. And there were some algorithms that reduce them, some that perpetuate or exacerbate them, marked color-coded here, and different types of outcomes that we're looking at. Some of them are intermediate outcomes, some of them are more final outcomes like, heart attack or death, for example. And I'm happy to, answer questions about, big picture, what we saw here. I think ultimately the takeaways were that you can perpetuate or exacerbate disparities regardless of whether race or ethnicity is included in an algorithm. And that occasionally there are some examples of actually using race and ethnicity to tackle disparities. And often that is when there were pre-existing disparities that existed in a clinical condition. So prostate cancer is one example. Another example is kidney transplant suitability. And then they put race and ethnicity in there to tackle those health disparities. Likely because race, there's debates as to whether that's the case or not, but that's, I think, what many experts believe. And so then the second question was, what are strategies to actually mitigate this racial and ethnic bias? And here we found in the evidence base 7 different strategies. And so you can imagine this is a very dense and complicated review where we really looked at how people removed race from, dozens and dozens of algorithms. And just to show one example of how complex it is, this is just one strategy for one algorithm. So it's what happens if we remove race from this kidney function equation. And you can see that there is actually trade-off in outcomes. So you're going to improve out certain types of outcomes, as shown in green, and then you're going to worsen certain other types of outcomes. And the reason this is so important is because when we make clinical decisions and when we develop guidelines, there is an inherent discussion about how you value these trade-off in outcomes, as well as, your moral and ethical rationale for suggesting that, race should be included in these algorithms. And so, ultimately for this one, we concluded that removing race may include the likelihood of diagnosis of chronic and severe kidney disease, which could, result in broader and earlier eligibility for kidney transplant. But it may also reduce access to other types of treatment, affect medication dosing, and reduce enrollment of Black patients in clinical trials. So I think I'll stop there, just so that I'm not, taking up the whole time screen sharing, but I'm happy to show figures and answer questions.
Wonderful. Thank you for that. A really helpful overview, and really appreciated hearing about how all these efforts to remove race. Could we hear a little bit from you about why and how algorithms began including race in the first place, and if there are different reasons that different algorithms include the term?
I think that's a really important question. So first of all, there's 2 different types of algorithms. There's our traditional statistical models that we all learn in our epidemiology classes, where we are it's hypothesis driven. Every single input that goes in needs to have a hypothesized relationship with the outcome. And it's true that historically, in many of our classes, we've been taught that age, sex, and race are biologic and they essentially affect all outcomes. But we sequenced the human genome in 2003, the entire human genome. And what the fields of population genomic studies has shown us is that there is more genetic variation within a racial category than amongst them. That genetic ancestry does not track with race. And I think this was something that, I mean, I didn't go to medical school that long ago, but long enough ago that this was, you know, kind of blew everyone's minds and people still have not wrapped their heads around it. And so, you know, these notions that race is biologic has really perpetuated. Of course, there are differences in, you know, genetics, but we should be using that as a more precise variable, identify that gene and use that to, you know, identify high-risk patients and, you know, to imply that, you know, all Asians, regardless of, you know, where in Asia, or all Black individuals, regardless of whether you, your ancestors were enslaved or you came from the Caribbean or you immigrated from Africa this generation, like they're so genetically different. There's such broad heterogeneous categories. And then there's also the arbitrary nature as to how these categories are defined. The definition of the categories vary by country, and then they've also changed over time. So clearly it's a social construct, but I think for a long time it was believed to be biologic, and by default, there were many algorithms that included race to begin with.
Thank you. In terms of how the use of race and how these algorithms are actually used to make clinical decisions, are there particular aspects of healthcare that are especially affected by the use of these algorithms?
So I would argue that it affects every single aspect of healthcare, from diagnosis to treatment to resource allocation. I started off by saying there are two types of algorithms. So the first one is the traditional statistical models that I said, where we have to hypothesize the relationship with an outcome and people believed it was biologic. But the second type is more machine learning and artificial intelligence, where model fit and predictive accuracy is prioritized over any sort of hypothesized biologic relationship between the variables and the outcomes. And so that is another area where race can slip in very easily. And sometimes that happens because race is really just being used as a proxy for some other variable, maybe a gene. But if that is not in our data set, then race is going to come out as being like a significant predictor. Whereas if you just actually took the actual gene, that's like a much stronger predictor, and you can actually take race out. So similarly, you know, all of these things are embedded in our electronic health record system, how we care for patients, how we triage patients, et cetera. So it really, I think, in the continuum of clinical care, algorithms affect very much our day-to-day practice of healthcare.
What is being done now by professional societies, the FDA, or others, medical advocacy groups, or others to address this issue?
Yeah, that's a great question. So, you know, the example that I gave you about kidney function equation, that was taken up by a professional society, which was the American Society of Nephrology and the National Kidney Foundation. They worked together, they convened a task force, and they developed a new algorithm that removed race. And now actually very quickly, many labs have now adopted this new eGFR calculation. So that's great. So professional societies, I think, are really leading the way. And that's one concrete example of that. In terms of broader initiatives, the Council of Medical Specialty Societies, which includes the kidney societies that I mentioned, as well as many of the primary care societies, they have just started an initiative. The CEO is Helen Burstyn. She's amazing and like truly an innovator, working with the Doris Duke Foundation, with funding from the Doris Duke Foundation, called Encoding Equity. And the goal is really to think carefully and critically about how algorithms use race and where and when and how those algorithms should be revised. And then similarly thinking about that in the guideline development process, which is separate but in some cases can codify an algorithm and tell clinicians to use one algorithm over another. So that aspect also needs to be addressed. So they're working on both of those from the professional society level. In terms of what is the government doing, so these types of traditional algorithms don't really fall under FDA. Like if it's a device like pulse ox, that's different. But there was a rule by HHS that I think is 1557 that essentially says that health systems need to ensure that algorithms that they're using are non-discriminatory. And I think it's very unclear to many people as to how to ensure that all your algorithms for which there's a lot of black box, honestly, in terms of how the EHR is putting it out, but are actually not causing problems. And so I think now a lot of the onus is on health systems to try to re-examine their own processes and the algorithms embedded in their systems.
Thank you. I do want to leave some time for audience questions, so I'll wrap it up with one last question for both of our panelists. How well has this issue been covered in the press, and are there story ideas or story angles you have not seen covered that you would recommend that our members look into?
I guess I'll start. So on the story of the pulse oximeter, I've talked a bit about what FDA has done and some sort of potential draft guidance about, a higher standard for evaluating pulse oximeters. I think one thing that we hear a little bit about that people are sort of catching on to, but hasn't really been sort of stressed in detail, is that the way these pulse oximeters are measured or evaluated are in these really ideal settings. So when a device manufacturer wants to sort of test their algorithm, they're really, or not their algorithm, their device, their pulse oximeter, they're testing them in a lab setting under just really idealized conditions. And the problem is that these devices aren't used under idealized conditions. They're used in hospitalized patients who are sick. They may have problems with perfusion, like blood flow into their fingers. And that's causing a lot of additional noise and additional inaccuracy. And so there's really a concern among some people that if the FDA sort of increases the number of patients who are getting tested to evaluate these devices, but these devices are only getting tested under idealized conditions, it may not solve the problem. Like if the device's major issues are coming up in these sort of non-idealized conditions, I think there is still a lot of concern that it's not going to address the issue. A lot of devices that are inaccurate under these imperfect conditions will slide through. It's like, I was trying to make an analogy here. It's like, if you were an airline manufacturer, right, and you only tested your airline in perfectly clear skies, right, like perfectly clear weather. I mean, essentially that's what's happening, but that's not how airlines are used. So I think that really needs to be considered a little bit more about whether or not we're actually testing the devices in the same way that they're actually being used in practice.
Yeah, well, so I can speak a little bit to the algorithms space. I think there's been some press coverage in this area. I've spoken to a few different groups. Stat News put out a series. Philadelphia Inquirer had something. There's been some press. I think what worries me, I would say, is that I think we've done a decent job in the ones that exist in discussing what are some of the most problematic algorithms, and a little bit of a discussion about what to do about that, how to fix it. But what I worry is as we take a year, 2 years, 3 years to convene a task force to reverse one algorithm, and that it's exact same period of time, new algorithms that are just as biased are being developed. And there's really very little concept of tracking the algorithms that are being developed, transparency about those algorithms. And there have been some proposals about what to do and how to do it. Nothing's really been studied very rigorously, but I think to me, that's what the focus needs to be on, really moving forward, because we can't tackle these things in silos. It really has to be in parallel.
All right, thank you. So we have a few questions that are starting to come in. And if you're at home and you have a question, please add that in the Q&A. One question, I think, Shazia, this is for you. I thought that the original EGRF studies showed differences based on race. Did recent studies show that there is no difference based on race?
So the original studies, yes, definitely did show that. I guess I'm not sure I understand the question, but I guess what I'll say is that the rationale for the race correction in the kidney function equation was that Black individuals have greater muscle mass. And that was based on like very flawed research and really hasn't been like properly validated in rigorous research. And so when they went to revise the equation, they found and they also did it in a more diverse population, they found that there were some minor differences still across racial and ethnic groups that they knew were not biologic. And like, to give an analogy, it would be like if we found out that all people from New Jersey, I'm from New Jersey, so I don't want anyone to be offended that I'm making fun of it, but are at like higher risk of a certain disease. We wouldn't be like, oh, okay, now all people from New Jersey should be screened differently or get different therapies or something like that. We would say like, oh, maybe it's because they're in two large cities. Like, what are the environmental exposures, right? Like, there's not like inherently biologically something different about people from New Jersey. So similarly, that is true for Black people, Asian people, white people, right? If you want to talk about genes, you can talk about that, but that's separate. And so even though there may be some differences of disease across racial and ethnic groups, it is not because of the racial and ethnic group. So the EGFR studies showed that there were some differences in serum creatinine for equivalent kidney function across racial and ethnic groups, but it's not because of the race. So to correct for race, many people argue, is morally and ethically like a false assumption that it's a biologically driven mechanism. So I think that answers that question, but the other way that question could be interpreted is just to say that EGFR was causing disparities, was leading to disparities in kidney function and kidney access to kidney care. And now with the new equation, that's starting to get reduced.
Okay. And one more question on the algorithms. Are there examples of race-based algorithms that benefit certain groups?
Yeah. So I think this is a really important question, and I'm going to answer this and another version of this question that I get often. So the answer is yes. So the kidney allocation system, which is different from the EGFR, which is like, how do you diagnose kidney disease, actually initially did not include race, but they noticed that there were a lot less Black patients getting kidneys. And so they included race in order to allocate organs, because they realized that Black patients who were equally as sick were getting less organs. So they actually intentionally added in race. Another example is in prostate cancer screening, where we had an original prediction model that said these are the patients at highest risk. But what we found over time was that Black men were getting more unnecessary biopsies, and that was leading to downstream cost and harms and consequences. And so essentially now all of the prostate cancer algorithms, including the one by the United States Preventive Services Task Force and Kaiser Permanente, now include race in order to avoid unnecessary biopsies in Black men. So those are two well-known examples where adding in race in an intentional effort to tackle disparities work. The really brief, sorry, I'm going to keep going, addition to that is that there are also examples of algorithms not including race that are really problematic. And that is when there's a differential effect of a variable across racial and ethnic groups. And there have been several in the electronic health record system that have been shown that we systematically allocate resources away from Black patients because whatever the proxy variable we're using, like cost as a proxy for need, is different across racial and ethnic groups, even if you're equally as sick.
Thank you. All right, Mike, I think this is a question for you. Do you think the FDA should take a stronger stance on pulse oximeter accuracy? Why can't the FDA block pulse oximeters that aren't accurate?
Yeah, so I'll answer the second part of that question first. So pulse oximeters are regulated by the FDA through the 510K pathway. And so for those who aren't familiar, I'm not sort of a legal expert on this space, but basically a manufacturer has to show that the device that they want to bring to market is substantially equivalent to some other device that's already on the market. So, pulse oximeters have been around for a long time. A new device they want to bring to the market, you just have to show that it's substantially equivalent, and then they provide sort of some guidance for how to do that. So inherently, the 510K pathway, I think, is a bit less rigorous than some of the other sort of pathways when you're bringing a brand new device to the market. So I do think, the FDA is sort of challenged by that. I think within their power, they are sort of trying to take a stronger stance on ensuring these devices are accurate. And people have sort of requested that the devices are labeled better, more clearly labeled about sort of the potential inaccuracies of the devices. And I think the other thing that FDA is considering right now is to actually measure if there's any difference in the accuracy across groups, which shockingly they haven't in the past. They didn't even require that. So in the sort of the guidance that's hopefully will come out, they will actually mandate that as part of the pre-market evaluation, you actually compare accuracy across groups and demonstrate that that there's a minimal difference in accuracy. So I think they're moving at the pace that they move towards taking a stronger stance. I mean, I do think there is a lot of industry influence on these decisions, for better or for worse. And as when FDA sort of comes up with draft guidance, they get a lot of public comment on this, and they get a lot of industry comment on this. And I think FDA is probably also sort of worried about stifling the ability to have pulse oximeters in the market. And so I don't think they want to sort of act too hastily, because like I said, I started by saying that, like, it's an amazing technology. Like, before we had pulse oximeters, we couldn't actually measure oxygen saturation in the blood, and so I think FDA doesn't want to sort of stifle the ability for people to sort of get access to these devices. And so they really are sort of fighting this balancing act.
Yeah, thank you. Another question. Are there any tips on how to localize stories on this topic? Like if you were writing, I guess, for a regional publication, local publication.
Yeah, I'll take this, and then maybe my other panelists has any ideas. This has been hard for pulse oximeters because, I've had reporters ask me, do you know of a patient who has been harmed by a device? And it's hard because, like, most of the time you don't know, right? Because the device is inaccurate and you have no idea. And doctors have no idea too, unless they take the time to sort of measure the more invasive device. No one knows. So it's kind of, I think it's been difficult to sort of find stories of people who have sort of had trouble, had an issue with these devices. I've seen stories where reporters have identified and spoken to people, but it is hard because it's such a big unknown that, like, most people have no idea that, like, this device that they've been using is inaccurate.
Yeah, I mean, I think outside of the device space, there have been some studies talking about patients who, didn't previously qualify for kidney transplant, but now with the revised eGFR, they qualify, they're on the wait list. So I think that is, and that's also a more common clinical condition and a little bit more direct. And similarly, I think when we look at diagnostic algorithms, like the kidney function equation, it's more easy to find people and really attribute the algorithm to having a direct effect. But when we look at prognostic algorithms, it's much harder because clinical decision-making is much more complicated. And so The algorithm that comes up all the time is vaginal birth after cesarean section, which initially said that if you are Black, you would be less likely to be offered a vaginal birth after having a cesarean section, and Black was actually included as part of that algorithm, Black race. But there also needs to be that data that a clinician then took that output of that calculator and did not offer it to the patient. So really attributing the algorithm, as opposed to like clinician implicit bias or other issues with systemic racism, can be really challenging to make that link and that connection.
Yeah, thanks. What strategies are there for health education, both healthcare provider, health education about the harms of race-based clinical equations, and community health education to better inform patients to make optimized, informed decisions about their health? A long question. But...
Yeah, I think the professional societies are starting to do a better job of, educating clinicians on these issues with algorithms. I think there was very little awareness from the patient's perspective. Part of what we did, it's not in the Annals publication, but in the AHRQ report, there were several other areas, and one of them that we looked at as patient perspectives, and there's just very little published, and most patients are unaware. And the problem is that clinicians are often unaware too. So even if in a patient encounter, you came to your clinician and you said, what's being used, maybe a clinician could rattle off a few, but probably couldn't tell you a comprehensive list. And this is, I think, where it comes down to transparency, where we need to require algorithm developers and implementers to make it very clear that an algorithm was used for a certain clinical decision, or even for resource allocation, which, like, how do we prioritize appointments for patients? Like, things like the algorithms are literally embedded in everything that can have systematic bias. And oftentimes clinicians just don't even know that they're being used.
Yeah. Okay, last question. Another question that came in. At a time that race calculators are seen as archaic throwbacks to racial pseudoscience, and race is understood as a social construct, not based in biology or genetics, why would we add a race adjustment?
Yeah, so I think in general, most people don't think you should. Okay, so I'll just start off by saying there are experts in both algorithm development and health equity who widely disagree on the answer to that question. So just to make that clear, I think that's the problem, that there's not great consensus. Some people believe that you should never justify using race because it is not biologic, and you're just perpetuating the notion that it's biologic, and you just need to figure out what the proxies are and put that in there. But I think similar to the pulse oximeter issue is that we've been using these for a long, long time, and we don't know what's going to happen when we take away race, that we actually may take away resources and therapies for patients who need it the most. And I think there's more work that needs to be done in order to better understand how reversing that can have impact.
Okay. Excuse me. And then this question is a little bit long, so I'll try and read it quickly. With respect to algorithms, experts often disagree on the best approach. Some medical journals say that, or some medical journal papers, say that the inclusion or exclusion of a racial calculator does not improve accuracy. Each option involves trade-offs. These trade-offs can be eligibility for clinical trials, eligibility for disability compensation, certain kinds of jobs, and prioritization for organ transplants that reshuffles patients' positions in line based on race. How confident are you that the decisions we're making now are not biased?
Yeah, so I think there's two aspects to this. One is, what does the algorithm do in itself? If race is not biologic, we should avoid, like many people believe, we should avoid including race into the algorithm, period. The second question is, how do we balance trade-offs and patient values and preferences, benefits and harms? And that is actually a separate process from algorithm development, because the algorithm is really just like a mathematical model that's supposed to give you a disease risk or estimate. A guideline is where you take the actual process to create a guideline is very different from developing an algorithm. So what happens is you do a systematic review of the entire evidence base, you convene a guideline panel, and then you use a methodology called GRADE methodology. And that methodology includes something called an evidence to decision framework. That framework is a transparent table of decisions that the guideline panel makes that clearly outlines the trade-offs that they are using to say that we should or should not do this. So something might be very effective, but it may also be very costly. There might be adverse effects. You might have toxicity from a therapy. And the reason why that's important is because it is true that somebody can look at the entire evidence base and come to a different conclusion, to your point about, valuing different trade-offs differently. But if you're transparent about what those trade-offs are, and you actually provide, like statistically, we use something called meta-analysis to show how across studies, what is the summary estimate of an intervention on a certain outcome, whether it's good or bad, that then somebody can say, yeah, I'm willing to take that little bit of harm for this benefit. And because I can see transparently where those trade-offs and values and of harms and benefits are, I can make a decision based off of my population and my health system, et cetera. So those are two different processes, but I do think that we do need greater transparency as well in how guideline panels are making these decisions and what trade-offs are there.
Thank you both so much. I want to jump in with one last question that is especially relevant to our audience of journalists. We're often covering new devices or new algorithms or new tools that are being introduced. What questions do journalists ask when we're doing these stories to improve awareness of the potential for disparities and work towards the transparency that we're hoping to achieve?
So I think one is just asking, what are the inputs into the algorithm? Two is, what kind of patients has this been tested in? I think we both have kind of talked about representation, diversity. Is the population that you're applying the algorithm to reflective of the population that the data that the model was trained in, and then further validated. And then, the other thing that I think in terms of transparency that we need is just better understanding, have there been disparities that have been noted in certain types of data sets, and how have those been handled? And there's actually something called model cards or data sheets that can go with every algorithm that theoretically are supposed to track all of these changes to algorithms, but they're not currently mandated, and they're not really used consistently. But I think those are the types of questions I think that we could try to ask, like, can you show us transparently what's in this algorithm? What's the purpose? What's the validation like?
Yeah, and just to sort of reemphasize again this issue of making sure these devices are getting evaluated on a diversity of participants from different backgrounds. I think for the pulse oximeter story, when these devices were first coming on the market, people don't really think that they were tested on a diverse group of patients. And so for many years, even though these devices were probably less accurate in patients with darker pigment, it just wasn't known, just because the sort of the testing population wasn't very diverse. And so I think there's been lots of efforts, I think, across medicine to increase diversity of patients for clinical studies, and it's hard. And I think in the past there has been some hesitation to increase the diversity of the population to test pulse oximeters, because it's hard to recruit and bring in patients from diverse backgrounds. But it's necessary, and so there just needs to be a commitment to making sure the devices are tested in a diverse population.
Thank you both so much for your insights today and for making the time to join us. Thank you to everyone in the audience who tuned in today. If you joined us late, you will find the recording of this webinar at healthjournalism.org in just a few hours. AHCJ will continue to bring you webinars on a variety of health topics as a perk of your membership. Join us tomorrow afternoon as our colleague Tara Haley moderates a program on reporting the respiratory triple threat, preparing for flu, COVID, and RSV season. Have a great day and good luck on your stories.